Good morning and good afternoon, good evening to everyone, depending on where you are joining us from. And welcome to our week 6 of the IPC webinars. And today we're going to be discussing injection safety, sharp objects, and waste management. But before we go into details with our sessions for this morning, my name is Lizzie and I'm from ICAN. And just to kickstart today's session, I just wanted to kindly remind us of a few housekeeping issues. Would like to kindly ask you to put your microphones on mute. And please note that if you have any questions, please put them on the Q&A box. And then for any other comments or chats, you can make use of the chat box. And then our sessions are being recorded, and we have Portuguese and Arabic translation for this session. And for you to qualify to be given a certificate of attendance, you have to at least have attended 4 out of the 6 webinars, and you should ensure that you should have been logged on for at least 1 hour out of the 1 hour 30 minutes. So the certificates shall be given at the end of the series, and each series has 6 weeks. And without wasting much time, I would like to introduce our first speaker, who is Dr. Bernard Barrikia from Africa CDC, to give us an introduction on COVID-19 and the current status in Africa. Dr. Bernard, over to you. Thank you.
Thank you very much. Good morning, good afternoon, wherever you are. My pleasure. If I can have the slides on, please. Thank you very much. So today I'll walk you through the epidemiological situation as of 15th June 2021. Next slide. Thank you. Beginning with the global situation, to the left is a world map showing the distribution of confirmed cases by country, and the dark blue color indicates the countries reported over 1 million cases since the pandemic began. That is in January 2020. On the right is the epic curve showing the number of new COVID-19 cases reported from the 6 Wuhan regions. And the number of the new cases being reported globally continues to decrease, with more than 2.6 million new cases reported through the past week, with 12% decrease compared to the previous week. So in the past week, the Southeast Asia region reported a marked decline in the number of new cases, while the African region reported an increase as compared to the previous week. So Africa accounted for 4.3% cases reported globally this week. So as of 15th June, this is 2021, over 176 million cases have been reported globally, with more than 3.8 million deaths, and the global case fatality rate comes to 2.2. Next slide, please. Thank you. On this slide, we are showing you the distribution of cumulative cases confirmed by African Union member states and the number of new cases reported by day, which has not changed really. So in the epic curve on the right is showing the number of new cases, that is y-axis, reported. And the red line is the 7-day moving average. And the 5 AU regions have been differentiated by colors, as we see on our map. So the trend of new cases being reported by the day is still on the upward trend overall. Cumulatively, over 5 million cases have been reported, with over 135,000 deaths, resulting in a case fatality of 2.7. So of these reported, 89% have recovered. These are the good news. Next slide, please. Thank you. This table is showing the distribution of new and cumulative COVID-19 cases, deaths, and recoveries reported by African Union member states. As of 9 a.m. today, over 87,000 new cases, more than 1,800 new deaths, and over 69,000 new recoveries have been reported from 50 member states in the past week. The Northern and Southern region accounted for 79 of the new cases reported. The Northern region reported the highest number of deaths this week. And we again go to see South Africa, Tunisia, Egypt, Zambia, and Uganda accounted for 70% of the new cases reported on the continent. Next slide, please. Thank you. On this slide, we show you the incidence per 1 million population per day by African Union member states. This is the distribution of new COVID cases reported per 1 million population per day. So across the continent, we have grouped the incidence into 5 categories. We have grouped the incidence into 5 categories. This is in the past epidemiological week. 30 countries reported less than 5 cases per day, as we are saying on our legend. And 15 countries reported between 5 to 50 cases per 1 million population.
My test is negative, no COVID detected, luckily. I just had a spot of diarrhea and vomiting.
There's a background noise.
So did my grandchild and my son.
Hi, Michelle.
So I think it was
Sorry.
just or
Michelle, may you kindly mute? Thank you.
Thank you. Let me start again on this slide. So on this slide, we are showing you the incidence per 1 million population per day by the African Union member states. And as I mentioned, we have grouped the incidence into 5 categories. In the past epidemiological week, 30 countries reported less than to 5 new cases per day. Then 15 countries reported between 5 and 15 new cases per day. 2 countries reported between 51 and 100 new cases per day. And these are Zambia and Botswana. While 5 countries, Seychelles, Namibia, Tunisia, Cape Verde, and South Africa are reporting more than 100 new cases per million population per day. So this week, again, we say we do not have information for the 3 member states, and these include Sahrawi Republic, South Sudan, and Tanzania. Next slide, please. Thank you. So on this slide, yes, thank you. On this slide, we are showing you the COVID-19 case fatality rate by African Union member states. There are 5 categories again on this. We have 11 countries that have case fatality that is less than or equal to 1%. 2 countries that have case fatality rate that is greater than 1 and less than 2.2%. Then we have 17 countries. Hello, are we on the same slide? I think you mentioned, you kept on the same slide, please. If you can move to the next slide. Thank you. We have 17 countries that have a case fatality rate that is greater than 2.2 and less in this perspective. Next slide, please. Next slide, thank you. On this slide, we do show you since February last year, more than, next slide, please. The total COVID-19 tests, that's the next slide. Thank you, that is the right slide. Since February last year, more than 48.6 million have been conducted across the continent, and the overall test per case ratio in the test positivity are 9.9 and 10.1 respectively.
Digamos, uma taxa de 10.9 e 10.1 em termos de testes reportados.
The chart on this slide is showing the number of new SARS-CoV-2 tests showed by the gold bar and the cases in the red bar. Our slide is moving, is not stable. If you can take me back to the total COVID-19 tests conducted in Africa. Thank you. So, we are showing you the number of I was saying the chart on this slide is showing the number of new SARS-CoV-2 tests. These are shown by the gold bar and the cases are shown by red bar. So on the left, this is y-axis, as well as on the test positivity ratio being shown on the right y-axis. But by the epidemiological week, yes, this is according to this epidemiological week. So this past epi week, we have 835,643 new tests that were performed, which is a 13% decrease in the number of the tests conducted compared to the previous week, with the test per case ratio being 10%. So the positivity rate here is still consistently above 5%. If you can move to the next slide. Thank you. So on this slide, we show you the test positivity by African Union member states for the past epidemiological week. We have 15 countries that have test positivity less than 2%, and 14 countries have test positivity greater than 2 to 7%. 4 countries have test positivity above 7 to 10%, and 10 countries have a test positivity greater than 10%. Again, we do not have the lab information from the 12 countries on this week as we show on our legend. I thank you very much. Over.
Thank you, Dr. Bernard, for giving us that insight into the status of what is happening in Africa and also globally. I think it is really talking to us as IPC practitioners so that we get to ensure and also maintain the momentum with regards to IPC awareness in our respective countries. So without wasting much of the time, I'm going to introduce our next speaker, with Dr. Deborah Barasa, who is going to take us through the injection safety and sharp objects. Dr. Deborah Barasa is an internal medicine physician with an interest in infectious disease. She has more than 12 years experience running the HIV programs in the Eastern Slabs of Nairobi, and above 10 years, or more than 10 years, working in a hospital setting, including the National Referral Hospital in Kenya. She has participated in the launching of the Eastern Central African College of Physicians in Kenya and is very instrumental in the mentorship, training, and support supervision of clinical staff in the medical wards, both at national and regional platforms. Currently, she is supporting the IPC pillar in the WHO as a hub. Over to you, Dr. Deborah, and welcome. Thank you.
Thank you very much, colleagues, for having me here today to present one of the most interesting and passionate topics, that is health worker protection, because I know it affects all of us as healthcare workers, and it's actually important that we improve healthcare worker safety from regional even to facility level. So today, I will be talking to you about injection safety. So this was quite a broad topic. Actually, it would take a couple of days to discuss it, and I'm really trying to narrow it down to something that is quite specific, but being able to help each one of us, especially for us as IPC focal points, as well as improving advocacy as part of healthcare worker safety. I don't know, my slides are not moving. So this is my outline. We'll talk about the problem of unsafe injections, and then look at the best practices and guidance for safe injection, needlestick injury prevention, as well as injection safety implementation strategy. So this is actually a module that I'm using, one of the modules that has been provided by WHO, and really the sessions that were in this module would include the problem of unsafe injections. We look into the definition of unsafe injection and drivers of the same, the risks associated with unsafe injection and magnitude of it in our setting. And then look at the IPC best practices and guidance to help us eliminate unnecessary injections, educate patients and community, and look into the safety engineered injections. Then we look at needlestick injury and how we can prevent it, as well as injection safety implementation strategy from national even to facility level. So before I start, I would like to say that as IPC focal points, we need to identify unsafe injection practices. There are challenges of reuse of injections, unnecessary use of injections, unsafe preparation, unsafe vials, as well as unsafe handling, sharp handling. Then we need to conduct injection safety assessment, as well as look at measures to improve injection safety. We need to have a strategic plan, short as well as long-term plans for injection safety, and also educate injection prescribers. So we need to look at all these aspects as IPC focal points, both from regional even to facility level. So we really wanted to describe the reason and factors behind unnecessary and unsafe injections and explain the risks associated with it, the WHO recommendations, mechanisms of safety engineered syringes, the 7 steps to safe injections, and how to collect, handle, and dispose needles, and any details of needlestick injuries, as well as associated preventions. So what is a safe injection? A safe injection does not harm the recipient, does not expose the provider to any avoidable risks, and does not result in any waste that is dangerous for others. So that is the WHO definition. So in any of the steps to make an injection safe are not undertaken appropriately, especially if the injection is given in an environment that is not clean, where the syringes are used for more than one patient, where the package is not sterile, new or sealed, the vial is used in multiple patients, the skin is not properly disinfected, the needle is not disposed safely, or where an injection is unnecessary and may cause harm, then those are unsafe practices for injection. So why do we, why do patients prefer injections? Patients from various studies, we have seen that patients prefer injections because they think that it's a stronger medication, it works faster, is a marker of efficacy, and it's more efficient. Equally, some of them think that it's a more developed technology. And so we need to involve our communication team and really allay these misconceptions or misinformation about injections. And then what about us as healthcare workers? We may receive financial incentives from medical companies. We may have beliefs that there's a better efficacy to injections as compared to oral medications, as well as really looking at the directly observed therapy. You may give a patient oral medications and they are not compliant to it. And so one may revert to injectables. So these are things that we need to also allay. And what about the providers? There's lack of awareness, and at times there's maybe lack of the oral medications, and so they may opt for that. And also when you look at the manufacturers, some of these medically, the safe engineered injections may be quite pricey, and so they may opt for these cheap injections that actually are not safe for the healthcare worker. So what are the risks associated with unsafe injection? Even as we look at these myths, we need to look at the risks associated with unsafe injections. Of course, we know that blood-borne pathogens, HIV, hepatitis C, hepatitis B, and viral hemorrhagic fevers, one can develop all these from getting a needlestick injury. The patient may have abscesses, which are septic or aseptic. There may be nerve damage causing paralysis to the patient. And then less frequently, malaria can also occur. Hepatitis B virus can stay 7 days outside the body. Hepatitis C up to 3 weeks, and HIV in a dried blood can stay at room temperature up to 3 days. And yet there's estimated risk of getting these infections from contaminated syringes during that time. Like for hepatitis B, there's a risk of 30%, hepatitis C 3%, and HIV 0.3%. So whenever we give injections, let us know that there are actually risks of transmission that can be as high as 30% as seen in hepatitis B. And then we look at the worldwide use of injection. We usually use 16.7 billion per year. And actually with now the campaign and vaccination for COVID-19, we'll have a further increase in use of injectables during this time. And most of the time, 90 to 95% are used in therapeutics, with more than 70% being unnecessary, and one may opt for oral medications. So we ask ourselves, even as we conduct campaigns for safe injections, are we giving all the patients the right medications, or we may opt for oral medications? And then we see that there's an annual new case of hepatitis B. 30% of hepatitis Hepatitis B new cases, 41% of hepatitis C, and 9% of HIV due to unsafe injections. So we need to really look into the cost versus benefits of, the risks versus the benefits of giving injections versus oral medications, and how to give safe injections in the healthcare setting. So we look at the IPC best practices, and really, one of the best practices is how to, look at eliminating unnecessary injections. And so we have some advocacy papers as WHO, which you can utilize. The links will be shared to each one of you on educational leaflets for patients and communities, and postcards for patients and communities, really to create awareness on how to make smart injection choices, making safe injection choices, how injections can be unsafe, preventing, looking at the best medicine or the best way to reduce injections, unsafe injections, among others. So these will be shared with each one of us. And here we have animated videos for patients and communities, as well as more infographics and for patients and community. So as WHO, to curb this, we wanted to look at a few things. One of them is to reduce the reuse of injections, to reduce accidental needle injuries, reduce overuse of injection, and reduce unsafe sharp wastes. And by 2020, we want to ensure that this rational, we wanted to ensure by 2020 we have rational use of injectable drugs and sufficient supply availability. So we continue to advocate for this and push in this regards. We look at the 2015 WHO policy, and we really wanted to look into the transition to auto-disable, reuse, prevention, and sharp injury protection devices. And also recommendation to develop standards for rational use and supply of standard disposable syringes, call partners to fund procurement of safety engineered injection devices, call to industries to switch to the safe syringes, as well as to call to countries to develop national policies and implementation strategies with a special focus on curative settings. So we really continue advocating for this policy even until now. So here we have the safety engineered syringes or devices, as we talked about them, the RUPs, the SIPs, and the auto-disabled. And so really, first of all, the RUPs have the self-locking mechanism that allows only one use, while the safe injury prevention have they are designed in a way that they have a component attached to them which protects the user from sharp injury. So these are the needles that we are advocating for health worker safety. So for the 7 steps to safe injections, I think all of us know this as IPC focal points. And we are really talking about cleaning the workspace, hand hygiene, sterile safety engineered syringes, sterile vial of medication and diluent, skin cleaning, appropriate collection of sharps, and appropriate waste management. So as WHO, we have also advocates of materials are there and guidelines for best injection practices. And really what we are saying is that the use of sterile syringes and needles needs to be from a new and damaged packaging, and we need to prevent viral contamination. For instance, we need to pierce the septum with a sterile needle, and select pop-open ampules where possible. And for the ampules that are requiring metal foil, we need to also protect our fingers. For instance, we can use the gauze pad to do this. And then it's important to utilize the single dose vial as much as possible compared to the multiple dose vial. And also in the multiple, if we're using the multiple dose, then we need to observe certain strategies. Then we should not leave the needle in the stopper, because this can actually lead to contamination of the medication. So also to prevent contamination of injection equipments and medications, we need to follow products specific recommendations, clean the designated area, ensure that we're not using medications that have visible contamination like cracks and leaks, and that we do not use syringes that have already been torn and punctured. We'll look at that very soon. And we need to discard needles that have already touched and sterile area. And let us not forget the 5 moments of hand hygiene, even as we look at these issues. So the use of gloves has been very controversial. And I think we really need to look at this table. I think last time when we were talking about IPC vaccination, a few people had raised concern about the use of gloves during vaccination. And you can see clearly in the base of this triangle that the rate patient exposure, taking blood pressure, temperature, performing subcutaneous and iron injections, we actually do not use gloves. So we will share with this to look at this triangulation and see where do we need to use gloves and when don't we need to use gloves. But of course, this is a caveat. When the patient has breach of the skin, maybe dermatitis, then there's need to protect ourselves and use gloves when necessary. So as we said about visual inspection of packaging, we need to look at the type of syringe, the volume, the needle, of the size of the needle, expiry date, and the method of sterilization. Some of the needles are contaminated, some are already open, and so moisture has settled in, and hence infection may also have settled in. So we need to ensure that the needles that we use are well packaged and have the right information before utilization. So this is about preventing viral contamination. And we said that single dose are preferred to the multi-dose vials. And many studies have shown that many outbreaks have been associated with use of multi-dose medication vials. And preservatives are effective, but not eradicate microbial contamination. So even as we do this, we need to really look into the issue of multi-dose vials. And if we choose to use them, then maybe we need to dedicate to a single patient and keep, and it needs to be kept and accessible within the nursing station. And the treatment area, as I said, should be dedicated to one patient. So as you can see on my right column, you can see that one of us has left a needle within the medication, and this will actually lead to contamination of the same. So we are saying that we always pierce the septum of the vial with a sterile needle, and we avoid leaving the needle in the stopper, because a needle left in the stopper of a multi-dose vial is an open door to contamination. And with practice, this practice has been associated with the reuse of injection equipment on another or even on the same patient, and this can actually lead to cross-infection. So let us avoid that when we are practicing. Another thing is preventing contamination and protecting our hands. As we said, we need to protect our fingers with a clean barrier, like a small gauze when opening ampules. And for preventing contamination ampule usage, we need to select pop-open ampules rather than ampules that require use of a metal file. And this is because for the metal files, they can break easily and they can cause laceration of the fingers, leading to contamination of yourself as well as the healthcare worker as well as the patient. So for skin cleaning, we recommend the application of 60 to 70% alcohol-based solution, that is isopropyl alcohol or ethanol, on a single-use swab or a cotton wool ball. And we do not use methanol or methyl alcohol because of its safety. It's unsafe for human use. We need to wipe the area from the center of the injection, working outwards without going over the area. And we need to apply the solution for 30 minutes, then allow it to dry completely. As you can see on the right lower corner, one of the healthcare workers has put some cotton balls within the container, and this is not recommended. Yeah, we do not use cotton balls stored wet in a multi-use container because of the risks of infection. So let us also ensure that is addressed. So what about the safety boxes? We should never fill a safety box more than 3/4 full, and once full, it should be sealed shut and stored in a safe and secure place until it is ready for final disposal. And for the appropriate collection of sharps, we say that we never recap a needle after utilization, and place uncapped syringes and needle safety into the sharp containers immediately after use. And sharp containers should be accessible at every point of care and always within the arm's length. There's this tendency of people injecting patients and collecting all the needles and putting them at once. No, we are saying that for each use, then you need to dispose the needle to avoid injections, needlestick injuries for the health worker as well as for the patient. So for the seal, once closed and sealed, we encourage you not to open or empty or reuse sharp containers, because the presence of sharps outside can lead to needlestick injury. Opening and emptying can also lead to needlestick injury. And for waste management, I believe my colleague will discuss about it fully, so I will not cover the same. So in summary, unsafe injections, including unnecessary injections, are a global problem, and reuse of syringes and needles is a risk factor to transmitting bloodborne injections. Contamination is also a major risk, and we need to follow the 7 steps to preparing and giving an injection, and WHO key recommendations to use safety engineered syringes. So we will share with you again some resources summarizing the 7 steps for you to utilize and also disseminate in your country. Regarding needlestick injuries, this is really an area that we really need to look into. A study done in Iran on 344 healthcare workers showed that 50.2% of injuries had been reported. 67.8% of respondents had actually experienced a needlestick injury. And also in India, where we had 220 nurses and doctors in 2012, 49% had reported experiencing a needlestick injury, but only 31% reported to the system. Equally, when we bring it home in Nigeria, a cross-sectional study done on 122 health workers showed that 51% had needlestick injury in the past 12 months and 62% did not report. So 2 takeaway home messages is that one of infections in these slides is that infections are occurring, people are get needlestick injury, and they're actually not reporting it. And so we really need health workers
Hello. It seems we have lost Dr. Deborah. Maybe we can just allow a few minutes for her to try and log back as we continue. Dr.
Hello?
Deborah?
Sorry, I don't know where I lost you. My network is acting.
You can kindly continue.
Okay, apologies for that. So I was talking about infections and the infections that can occur. And what I was saying is that what should we do when there is when one has developed a needlestick injury, and how do we go about managing the same? So for hepatitis B virus, what has been shown to be efficacious of around 85 to 95% is a combination of hepatitis B immunoglobulins as well as a vaccine series. However, for hepatitis C virus, there is no immunoglobulins, and antivirals are actually not recommended. And steps after HCV exposure include a baseline testing for antibodies as well as an alanine aminotransferase testing. Okay. So for patients who turn to be HIV positive when a health worker has developed a needlestick injury, we need to encourage them to take post-exposure prophylaxis for 28 days as recommended by the WHO. And we need to really look into the other issues that come with the infection of HIV. And there's also need for reporting for HIV exposure. So basically what we are saying is when one has developed a needlestick injury, they need to wash their wound with soap and water, inform their supervisor for report, and there is need for a good reporting mechanism for your health facility. Identify the source patient who should be tested for HIV, hepatitis C and B. And also the health worker should be tested for HIV, hepatitis B and C, and we go through the WHO best practices for injection and related procedures, and they need to be informed about the protocol thereafter when the patient is HIV positive, hepatitis B or hepatitis C, to ensure there is no progression of disease that can ultimately lead to chronic complications. So for injection implementation, we need to, as we said, we need to reduce the reuse of injections, the accidental needlestick injuries, overuse of injection and sharp waste, and we need to ensure the rational use of injectable drugs and sufficient supply and availability. So from a facility level, there is need for commitment by the healthcare facility management, funds or budget allocation for injection safety, sensitization and awareness strategy for health workers, and procurement of safety engineered devices. They are on the market, so let us advocate for that. We need to train our health workers, and let us not forget the housekeeping, sanitation, and paramedics. At times we train our nurses and our doctors, but we forget that also these people are exposed and may not have enough knowledge on modes of transmission and how to address them or look into the IPC practices. So even as we conduct training, let us ensure that this group of people are also trained, informed on how they need to go about whenever they have developed a needlestick injury, to ensure that we protect each one of us. And we also need to educate our patients. As we said, there's a lot of misinformation. So we need to give them the materials that can educate them on unnecessary injections and how to and safe injection practices so that they are informed, and also look into the issues of waste management, as well as conduct an M&D system, have an M&D system to really evaluate and have a continuous quality improvement towards injection safety. For the national injection safety plan implementation strategy, there's need for political buy-in commitment, and communication strategy for advocacy and awareness raising is important. Then at national level, there's need for budget allocation and strategy for donor engagement, and industry engagement or procurement strategy, also looking into what we have talked about, the safety engineered devices. Target audiences, stakeholder engagement strategy to ensure also the procurement of the same, healthcare worker safety, education and training from national level, trickling down to the facility level, public awareness raising and patient education, as well as an M&D system. So in summary, these are the advocacy papers for healthcare providers, professionals, association, and industry members. These are IC materials that you can use in your facilities from national to facility level, and also some materials for safe injection for patients and community. Citizens can help make injections safe, among others. So that is it from me. Thank you very much.
Thank you, Dr. Barasa, for that informative lecture and taking us through the 7 steps of preparing and giving injections, and above all, the best IPC practices for our injection administration. I'm going to now invite our next speaker, Dr. Sowande, who is going to give us a session on waste management. Dr. Sowande is a public health physician. She has served as a country director of various USAID-funded projects from 2000 to 2016. She has worked with the government of Nigeria and other stakeholders to develop a national injection safety, IPC and healthcare waste management policies, guidelines, and plans. She has advocated for international standards for IPC and healthcare waste management to be adopted in country in Nigeria. She is also part of the CDC-funded College of Medicine of the University of Lagos, and is involved in the IPC curriculum development and implementation. This is what she is currently doing. She also is the current chair of the Nigeria Society for Infection Control and is active in several projects, including the Resolve to Save Lives, ICAN, and ECHO projects. Over to you, Dr. Sowande. Thank you. Dr. Sowande, over to you.
Thank you very much, Lizzie. I forgot to unmute myself. Can you hear me now?
Yes, we can hear you.
Yes. The topic is interwoven with injection safety, and I want to thank the last presenter because it's all together. My presentation is healthcare waste management with a view of infection prevention and control. And I want to take it in the context of Ebola and the current COVID-19 epidemic. And I just want us to have a walkthrough so that we can know what it's all about. My outline, well, I'm going to talk briefly to remind us about Ebola that started in Africa, and of course, COVID-19. And then we'll define what are healthcare waste. We will look at the classification and types of healthcare waste. Then we'll list the risk and hazards of healthcare waste. A bit of it has been mentioned, but we'll go further into it. And then we'll discuss the steps in best practices of healthcare waste management. And I will want to discuss the differences between the barriers from the dead body from these 2 major diseases we're talking about, Ebola, barriers from and COVID-19, to compare what are the differences, because this is part of healthcare waste management. And of course, I will conclude. Well, as a way of introduction, I want us to look at Ebola. I know this is just a refresher. I'm sure most of us are very conversant with this. Ebola virus disease was formerly known as Ebola hemorrhagic fever, which is a severe, often very fatal illness in human beings. The virus, of course, we know the transmission is from wild animals and spread to human population through human-to-human transmission. The average of Ebola virus disease case fertility is around 40%, but then it can go as high as 90 to 95% in past outbreak. I'm mentioning Ebola because we've had some countries in Africa that had both COVID-19 and Ebola together. so we need to at least have some background. It appeared in 1976 in two simultaneous outbreaks. In one, what is now known as Nzara, South Sudan, and the other in Yambutu, Democratic Republic of Congo. And the latter, which is the one, the Yambutu, is a village near the Ebola River, which is where we got the name from. The outbreak in West Africa, first cases was notified in March 2014, was the largest and most complex of the outbreaks since Ebola virus was known, and was first discovered in 1976 outside DR Congo. Ebola was introduced into the human population through close contacts with blood, secretions, organs, and other body fluids of infected animals, such as chimpanzees, gorillas, fruit bats, monkeys, forest antelope, concubines, which are often found ill or dead in the rainforest, which covers most of Africa. Where this is just a glimpse of what happened in West Africa at the end of the by the time Nigeria was declared free from Ebola. It all started in Guinea. Guinea, as at that time, the number of deaths was 296. Well, I'm sure it went higher than that, but the number of cases at that time was less than 600. From Guinea, it moved to Sierra Leone, and I know ICAN was involved in the response in Sierra Leone. We had 846 cases as at that time, with 374 deaths. And then Liberia had 834 with 576 deaths. And from Liberia, all these three countries were very close proximity. We know the borders in Africa is porous. But then how did it get to Nigeria? It came on an executive flight. One of the diplomats came for a meeting and brought it into Lagos. And then we had 20 cases, but 8 deaths. I'm just sharing this to show us the case fatality rates that we have said should be between 40 to 95. But then it is that bad. Or just as a way of refreshing our memories again, incubation is approximately then 8 days. But I know we still have, it's still endemic in DR Congo, so we still have to talk about it. 0 to 3 days, non-specific febrile fever, which is similar to what we have in COVID. Then from the 4th day to the 10 days, what do you have? Gastrointestinals in about 60 to 80% of cases, nausea, vomiting, diarrhea, occasionally with mucus, lower chest, epigastric pain, hiccups, cramps of diffuse abdominal pain, liver tenderness, conjunctival injection, dehydration with shock, hypovolemic shock. And of course, after 10 days, it progresses to neurological complications, hemorrhagic complications, which is what everybody has known it for. And then of course, the late complications is multi-organ failure, seizures, and death. And that is the picture of the Ebola virus. Now our COVID, or SARS-CoV-2, as is well known and is a global epidemic that has shaken the world, was first reported on the 31st of December, 2019 in Wuhan, China. I noticed that WHO is still trying to find out where did it come from? Is it from animals? Is it laboratory related? But that is just for our knowledge. But it was declared on the 11th of February, 2020, as a novel coronavirus that we now call it COVID-19. And we all know that it's spread by droplets and aerosol procedures. I want us to just have this at the back of our mind before I go into my healthcare waste management topic. And of course, with COVID, health systems have been overwhelmed all over the world. Well, I want to say that we are very lucky in Africa. But when, at the beginning, when we see pictures from Spain, from Italy, and Brazil, it's so frightening. But somehow God has been faithful. We've been lucky. Our health, I was thinking where our health system is not very strong. If we get overwhelmed, I don't know what will happen. All over the world, globally, health systems were overwhelmed with increased solid and medical waste because you have more people going to hospitals. And I know in Nigeria, you have to have isolation centers, you have to set up camps. Hotels were turned into isolation camps. And then, of course, there are increased face masks, gloves utilization, personal protective equipment, the mask, N95, and others were being generated, a lot at the testing and isolation centers, which will now take me to my healthcare waste. WHO defines healthcare waste as the total waste stream from a healthcare or research facility that includes both potential risk waste and non-risk waste materials. We will get to know why we need to mention this, and the effective management of healthcare waste depends on good administration and organization. The management is a multi-sectoral. If we want to have the best practices, it's got to be multi-sectorial. All stakeholders' hands has to be on deck. The management at all levels, the federal, state, the health facility, PAC, secondary isolation center must have good administration and organization system. We must have adequate legislation and financing. There has to be budgeting. I know in a lot of African countries, we budget to procure medicaments. We budget to procure syringes and needles. We budget to procure drugs, beds, hospital beds, but we forget to budget for healthcare waste management. But I know for COVID, best practices has to be applied. So of course they had to do that. And there has to be active participation by trained and informed staff. Because if the staffs are not trained, they will not know what to do, and then they will not know how to go about it. And followed by monitoring and continuous improvement. Rome was not built in a day. We can start from zero, but let's start from something and start to improve. I don't know what state your own facility are, but wherever you find yourself, you need to take action and you need to make sure you start putting things in place. You don't have to have an epidemic to have a sound healthcare waste management system in place. We should have it as a matter of routine. We know with the epidemic, everybody is aware, everybody does everything, but let's use that to improve and plan beyond this current epidemic. Now, when we say healthcare waste, we have said it's the total waste stream. It's a total waste stream from that facility, but they are not all hazardous waste. The general waste takes the bulk of it, and between 70 to 90% in a health facilities are non-hazardous, comparable to, we call it domestic waste or municipal waste. Potentially hazardous waste, including sharp waste, is associated with some health risk, and that is 10 to 25% in a health facility. And what is this one telling us? If we mix all these wastes together, they all become hazardous. So we need to know that it's just 10 to 25% that are hazardous. So what do we do to contain it? Now, this picture is just telling us that we need to contain the hazardous waste so we don't make all the waste coming out from our PAC, secondary, tertiary, or whatever level where care is being given hazardous. So it means we need to color and make sure it is obvious to anybody coming there to know that we have special colors as dictated by WHO. Red is for hazardous waste, and red is associated with danger. So anybody seeing red, you know, oh, this has to be handled properly. And where does the waste come from? from the labor ward, the laboratories, operating theaters, wards, including isolation centers. You know, the waste, and then the yellow is for, well, we'll talk about that later on. We should not keep it near the patient's bed because we are trying to contain infection. We don't want to spread it. Small red bags for dry waste. Sharp container, as just mentioned by the previous presenter, should be securely kept. It should not spill over because we're trying to avoid needlestick injury. Take to large receptacle, the red promptly, and use bottles for liquids because we have some liquid waste. And of course, black is for the general kitchen waste, wraps of our food, whatever we get. And these are used small or larger size in each ward, empty promptly into the municipal container. But we get to talk about the containers very soon, but this is just giving us a bull's eye view of what we need to do. Now, how do we classify our waste? We have said 10 to 25% are the hazardous or the risky waste. What are these risky waste? Infectious waste, anatomical waste, sharp, we just mentioned sharp. Initially, when injection safety came on, I remember in Nigeria, it was when we were talking about healthcare waste, it was only the immunization campaign. It was only safety boxes that were available. But we remember it was only 1% or 1 to 5% of the waste that are sharp waste. Chemical waste, pharmaceutical waste, radioactive, genotoxic, pressurized container, and waste with contents of heavy metals such as mercury and all that. They all have to be contained to ensure that we don't expose the populace to infection. And then the remaining 75 to 90% are the communal waste, what we call municipal waste. That is in black nylon bag, and that is the one we're all used to. That is what we generate from our homes, but we also generate it from the healthcare facilities where care is being given. Now, this is the color coded as dictated by WHO, and I just want to have a walk through this so that we know what goes into what. Some of us, this is just like a revision for us, but then for the ones whose facilities are not at this stage, we need to share this. The non-infectious waste we just said should, what are the examples? Paper, packaging, like I've said, plastic bottles. We have a lot of plastic bottles, food, cartons, goes into the black. They are the, I don't want to say innocent, but they too can be risky because if you don't keep it well and they get to generate, they can spread disease. Or infectious waste, we are more concerned about the infectious waste. And what are these? Gloves, dressing, blood, body fluid, used specimen containers, face masks. A lot of them are now available. Everybody is now putting on face masks. Should go into the infectious waste because you don't know what has contaminated it. Highly infectious. We have infectious and highly infectious. Usually we say anyone that has body fluids, especially blood, anatomical waste and pathological waste that comes from the laboratories, the veterinary centers. It's not just that, it should be in red containers. Chemical waste, formaldehyde, photographic chemicals, solvent, organic chemicals, inorganic chemicals should be kept in a brown container. And then, you know, these days we have radioactive waste from the lab, from the cancer treatment centers, any solid, liquid, or pathological waste contaminated with radioactive isotopes of any kind. That should be yellow, but to differentiate from the infectious waste, we must have the radioactive label to it so that anybody saying it know how to deal with it. So what are the risks? What risk are these infectious waste or hazardous waste? Risk probability, of course, my former presenter has mentioned needlestick injuries, and she has delved into that, and I don't have to go over that again. And of course, transmission of infections or disease, and in this context, Ebola, COVID-19, cholera, dysentery, hepatitis B, C, and HIV/AIDS. She's mentioned that. And the reuse of some types of waste. Where she mentioned reuse, syringe and needles, especially. It can be accidental, that is using it unknowingly. But because of that, the engineering, they have got the engineered single-use syringes that can be used, or it can be intentional in the community, because they will tell you, oh, is it not, are they not from the same family? It can be used. But then remember, one of them may have an infection and the other person doesn't have. So a lot of advocacy has to be done to let them know that this can lead. Then of course, the environmental pollution or degradation, air, water, exposure to radiation. I know that in some rural areas, some people will say, oh, we don't have to move, we don't have anything to contain the waste, or they haven't come to pick it up, and we need to get rid of this waste. And they decide to go to the back of the clinic and start burning. Remember, low temperatures burning will release furans and dioxin into the air and pollute the environment. And somebody somewhere is going to breathe in that air, and subsequently may lead to cancer of the lungs later in another 20, 30 years. So we need to take care of everything, that we don't, from the hospital, cause environmental pollution or degradation. We are talking about the environment. And of course, fires. If we are not careful, we can cause fires. So who are the people at risk? Who should we be looking at? Of course, all persons exposed to healthcare waste are potentially at risk of contamination from accidental exposure, because they unknowingly, I know in some places, in those days in Nigeria, you have expired drugs seized by our drug agency, thrown into if you throw it into an open dump that children can have access to it, they will go there and pick. But then when we talk about medical staff, nurses, doctors, anybody, medical staff working in the hospital are at risk if you don't take proper care, if you don't do the proper healthcare waste management. Health facility support staff, we shouldn't forget them. Housekeeping, cleaners, and even our patients, because they come to visit the hospital. You have visitors, and because waste are not properly taken care of, they can be exposed. The general public or communities, if we don't do it properly and we just go to the back, or we go to one bush and just dispose of. The management staff too, if they can be exposed. Mortuary workers, we tend to forget the mortuary workers who take care of the dead, forgetting that some of them must have died from either COVID or Ebola. We don't know what they died, but they do at risk. Service providers for collection and disposal of healthcare waste, the ward orderlies. Now, the risk severity, I just want us to walk through this. And the waste generators that I've just mentioned, which usually is at the service delivery point, where we give care. That person giving that injection, that person cleaning that wound, that person changing that dressing. So they are the most at risk. The risk is highest up there. The healthcare worker or the laboratory worker taking that blood, or taking that swab, or taking that nose swab for the COVID testing. And then down, the risk diminishes as we go down. The workers collecting and processing, the general public, the landfill or the healthcare waste management plants. If healthcare waste management plant can be on site, can be off site. And of course, the effluent, even when we have taken care of what we're doing, like I said, the environment is at risk. But we know we have some high temperature incinerators that will have scrubbers that will help to reduce whatever goes out, the furans and the dioxins that go into the air, so we don't expose our communities to risk. So how do we ensure that we contain this? Waste segregation. If we segregate at the point of giving care, we package, we store, and we transport. So containment is key. We have said 70 to 90% or 95% are non-hazardous. If we contain the infections, whether it is highly infectious or radioactive, if you contain them, we will not make the whole of the waste hazardous. Now, what do we find in those days? Early in 2006, 2005, you have commingling of waste because the head worker has not been educated. They don't think anything wrong in it. Everything is just jumbled up together, including municipal waste, and that's going to make everything. That sharp container is not meant to be there. It's supposed to have been put in a sharp container. And when we talk about sharp, I want to add that it's not just the syringe and needle or that needle, even the lancet for HIV screening, for when we do our screening and then we do a lot of, we go on massive screening, the lancet, the needle that is used for that X-ray of operation, or when we do ascites and we use that needle, it's got to be contained. How then can we manage waste and ensure the best practice, including having all the diseases at the back of our mind? We manage waste from cradle to grave. That is the layman's language. And when we say cradle to grave, we're talking about waste from the beginning of that production of that waste or the point of generation. That is the cradle. To the end of final treatment and disposal. That is the grave. Even after incinerating, even that ash, the effluent, the ash that comes out from it has to be properly buried in a way that it will not contaminate the underground water. So we manage waste from cradle to the grave. There are 8 steps in this cradle to grave management of healthcare waste, and I'm just going to quickly just run through it. We may not be able to do everything at this presentation, but at least give you an idea of what it's all about. The 8 steps, the number 1 is waste. We minimize it where you don't have to generate it where you don't have to. And that means, that's what my former presenter just said. We do not give unnecessary injection when there are alternatives. A lot of advocacy has to be done into it. We've seen pictures of people in Pakistan having needle, syringe and needle just at the back of their hair as if it's pencil, because they believe it is more efficacious. A lot of advocacy has to be done to ensure that we educate the community that they don't go, oh, this doctor did not give me injection, I'll go somewhere else where they give me injection. We are generating waste that we may not be able to take proper care of. And of course, number 2 is our waste generation. What did we say we should do? We should contain it at that point. Once we contain it at that point, then it makes it easier. The amount of money to be spent from cradle to grave will be manageable. So that's point 2. Point 3 is what I've just said. We segregate and we contain it. We contain it in the appropriate container. And once we do that, we're on the step to success. Number 4, we need to be handled, and there has to be intermediate storage in case we cannot do it immediately within the ward, within the hospital. And if you have to do off-site, intermediate we do at the hospital. Number 4 is internal connection and transportation. People to do this has to be trained. We know that there is going to be connection from ward A, B, C, D, and then it goes where. Number 6 is central storage and weighing There are studies to know how much waste is being generated. My hospital is 50-bed hospital. If I don't weigh, I may not be able to document how much waste I'm generating, and then I may not be able to appropriately talk to management or know how to deal and handle it well. And then off-site collection and transportation. I saw this in South Africa. 2015, 2014, we were there. They moved waste from Cape Town to outside by special contractors for proper handling. And that means there has to be off-site collection and transportation. And lastly, the proper treatment, appropriate treatment, and final disposal. Like I said, the ash pit has to be done. So this, I will now go on into the details. Step 1, like I've said, we want to prevent reuse and community exposure to waste.
Dr. Sawande, sorry, apologies. May you kindly round up? We are, yes, we have run out of time.
Okay, I'm just going to go quickly through what I have. These are just like sharp waste we've dealt with, personal protective covering. These are off-site, and options for autoclaving, and these are just examples of incinerators. But I just want to quickly just share this. COVID-19 barriers as different from Ebola. The body infectious, little risk for current information, but it is droplets, but Ebola bodies are highly infectious. Special team required, no for COVID-19, yes for Ebola. Can family prepare for burial? Yes for COVID, no for Ebola. How do you handle the belongings? Because that needs to be done. Washing, soap and water, and disinfectant and sun dry. But for Ebola, because of the way it is, we disinfect one. Can the body be viewed by the family? Yes for COVID, or for Ebola, no. Personal protective equipment, hand washing, gloves, hand gloves, water and soap. But this is just, and can burial be chosen for the family? Yes for COVID, but no for Ebola. But in conclusion, I just want to conclude that our goal to best practices is to decrease the burden of spread of disease, reduce the pollution associated with healthcare waste and its attendant effect on healthcare workers, patients, and the community. So I want to thank you very much for your attention. But for more information, you visit WHO Healthcare Waste Management or cdc.org/coronavirus. Thank you very much for your attention.
Thank you, Dr. Sawande, for that very insightful and educative segment on healthcare waste management, of which most of the participants would agree that it has been a problem in their facilities, and also for you getting to spend time into really delving on what is waste management and practical examples of what we can do in our various facilities. At this point of time, I would like to move then to the Q&A session, and welcome all the panelists that are present today. And seeing that we have limited time, I will quickly go into the questions. There is one from Obina E. This one is directed to you, Dr. Sawande. It says, are there any lessons, do you think that there are lessons the world should have learned from Ebola outbreak so that we could have better mitigated the incident of the COVID-19 outbreak? Over to you, Dr. Sawande.
Well, I would say that a lot of lessons, especially in the developing world. After Ebola, what happened? Everybody relaxed, especially in Africa, where I can talk for Nigeria. We should not be epidemic-driven. Infection control, healthcare waste management should not be epidemic-driven. That's when we now start looking for the proper thing to use. We should strengthen our system, and that would be the message Nigerian Society for Infection Control is preaching. We should use the epidemic, just like we say in injection safety, that when we have a measles campaign, that's when everything is put in place. But let's use it to strengthen our routine immunization. So I would say the lesson we should have learned that epidemics will come, but let us strengthen our system. Once the system is strengthened, anything can come, we'll be able to contain it. Well, I hope I've answered it.
Yes, thank you, Dr. Sowande, for that. The next question, I'm going to direct it to Dr. Deborah. Nati is asking, is it possible to recycle and to repurpose some of the waste which is generated in healthcare facilities? Oh, sorry. This one is also to you, Dr. Sowande. Sorry about that. Is it possible to
recycle? Well, I would not think we should recycle. I know at one point we were thinking about recycling plastics and all that, but with the epidemics, the global epidemic all around, I don't think that is advisable, especially if your healthcare waste management system is not good enough. The only thing you can recycle may be your PPE, your plastic aprons, or your goggles that you can, clean up with your chlorine water and all that. But for things that actually goes inside the body, it is not advisable. But I'm sure when you go deep into it, recycling, I don't think, well, for us in Lagos or in Nigeria, I don't think we have gotten to that stage yet.
Yeah, I think, can I say something to that?
Yes, go ahead. Go ahead. You are welcome.
Yeah, I think when we talk about recycling is a complex process. It's a kind of industrial term that means that you can turn your waste to produce another thing. So most of the plastic waste from healthcare workers are recyclable, for sure. They can turn them to another thing. But when it comes to healthcare facilities, what we need to be conscious of when we are talking about waste are the 3 R's. 3 R's. The 3 R's are, number one is reducing. We need to reduce the way we generate the waste. So something that is not necessary, we shouldn't use them. If we take the first R seriously, we reduce the amount of waste we generate. The second R is reuse. So there are some of the things, the materials we dispose from the healthcare facilities that are reusable. So we can reuse them. As Dr. Sowande just mentioned, so you can disinfect some of those materials and reuse them. But the third R is recycling. Recycling is an industrial term and it's a complex thing. It shouldn't be something that we'll be talking about at the healthcare facility level because it's a complex thing, and I don't think there are facilities for that in many countries that will turn those materials into another thing for us to use again. But when we take the 2 R's seriously, that is reducing and reuse, those are the things that we might have business with at the level of healthcare facilities. Over. Hello.
Hello.
Hello, Lizzie.
We lose her.
I think we lost Lizzie.
Hello?
Yeah, that is all from me.
Okay. Now, thank you so much, Dr. Ario. I'm saying that on the Q&A, I see there are a lot of questions on healthcare waste management, and some have been answered, while some are comments. So I'll take one from Daniel. He says, I thought that blood should be classified as highly infectious waste. Should it be discarded in the red color-coded container as against what was showcased by the presenter? Please kindly clarify. Over to you, Dr. Sowande.
One thing I did not mention is liquid waste. Blood, when you have a lot of, but that is liquid stroke solid, it should be in the red container. You have placenta go into the red bin or bag, where I didn't have time to explain that. But I remember during Ebola outbreak, even the urine, all the liquid waste, all the effluent from the toilet were kept in a receptacle for a number of days to ensure that the virus is dead. You know, it's gone, you know, at least for that period before it was let out. So blood is red. Of course, blood is highly infectious. It's not just anatomical waste and placenta. Blood is highly, highly infectious. Over and out.
Thank you, Dr. Sowande, for that. And then there was a question raised by Ezra, just to give Dr. Sowande time to take a glass of water, maybe from my colleagues from Africa CDC. Ezra is asking how long this program is going to run. Over to you, Dr. Ario or Dr. Wande.
Hi.
Yes, Dr. Wande, thank you.
Thank you very much. So yes, ideally, we are definitely seeing value in the webinars that we have been running since April 2020. So the idea is to continue these sessions as planned, 6-week series, at least up till the end of the year. Also addressing beyond COVID, other endemic outbreaks that we might be experiencing on the continent. So definitely as the Africa CDC, we plan to continue providing support to healthcare workers and member states through our webinars, at least till the end of the year. And we are working to make sure that we are able to do that. Over to you, Lizzie.
Thank you, Dr. Wande, for that. And we'll also now pick another question. Sorry, I'm taking a bit of time because there are some that are being answered through typing, and while some are comments. I'll take one from Emilia. Kindly discuss briefly if there are infectious disease risks associated with placenta, especially as some women request to take them home, often in the cellophane bags. What would be the most appropriate way to dispose of the placenta at home if this should be the case? Over to you. Anyone from the yes, Professor Wande and any of the panelists.
Yeah, I want to say that I know that's the practice, that's some customary practice in some parts of the rural areas, because they believe where your placenta is where you go back to. But you know, because not everybody knows their status. We don't know who is HIV positive, we don't know who is hepatitis B positive. Well, you know, abroad, you cannot collect your placenta and take it home. You cannot in the UK or US. But we need to do a lot of education. Apart from educating the healthcare workers, we need to educate the community so that they will know it is wrong. I will share a short story with you. When we were doing the healthcare waste management program in Abuja, we had the community awareness program, and then we brought people together. And one farmer said, okay, the hospital have been bringing placenta, and we've been telling them to put it so that our young will grow. Now we will stop them. So we need a lot of advocacy because they are walking around barefooted. Their legs are not covered. It is not the best practice. I know it happens, but you know, HIV did not come up until early 1980s. We need to now we need to let people know that it can be dangerous. But I know that is the practice, but it is not right. It is not right, but the earlier we can change that, the better for all of us. Over and out. I don't know if anybody has anything to add.
Thank you, Dr. Sowande. Anyone from the panelists who has any addition? All right, thank you. And our second from the last question is to Dr. Wande, who says she wants to answer it live. Does WHO or AUCDC have any policy on compensation of non-healthcare workers affected by waste or smoke from incinerator or waste that has not been disposed properly? Over to you, Dr. Yewande.
Yeah, thank you very much for that question. At the AU, we do not have any policy in place yet. And I reckon that my colleagues from AFRO and WHO do not have a policy specifically for your question. However, we do have a lot of overhacking documents that really focus on healthcare worker protection. And how, again, we are trying to work with the administrators to ensure that healthcare workers are adequately compensated for exposures on the job. But I think just to say that we have various strategies, legal frameworks, ideally, and policies that could serve as some quote unquote a strategy to protect healthcare workers. But specifically for your question, no, there is none, at least on the continent that I'm aware of. But again, I think beyond policies, there's a need for us to try to work with administrators. And that's what we are trying to do. A couple of series ago, we had this webinar series specifically for healthcare facility administrators and managers, so that some of these things that you are raising, we could try to address them and give them evidence-based solutions. Over to you, Lizzie.
Thank you, Dr. Wande. And then I'll take one last question. This is also directed to Dr. Sowande from Maslin. She says, we have classified waste that is used on patients without any signs and symptoms of infection and in non-epidemic situations as just clinical waste. Is that an inadequate or wrong classification? Over to you, Dr. Sowande, or any of the panelists. Thank you.
I'm not very, very clear on that, because he's saying that waste coming from the patient is clinical waste. Waste coming from the patient can be non-hazardous and can be hazardous. It depends on what type of waste, not necessarily during this epidemic. Remember that patient is going to eat. When they eat, they're going to have leftover food. When they have bread, they're going to have wrappers. Those are non-hazardous. But at the same time, when you do procedures that is going to expose either aerosol procedures or we're going to pierce the skin, then that becomes hazardous. Or you are dressing the wound and the body fluid is involved. Those are hazardous. That's, if I understand it well, I don't know if any of the panelists want to add to it. Because, you know, if you're talking about the patient per se does not produce clinical waste. That I did not link that clinical waste to the patient. Over
thank you.
And out.
Thank you, Dr. Sowande, for that. Anyone from the panelists who wants to add on to what Dr. Sowande has said? Okay, thank you so much. I see some of the questions are being responded to through the typing. And most of the questions are asking about the slides and the recordings. Please note that the recordings are going to be shared with you within the next 48 hours. And for you to get the certificate of attendance, you should have at least attended 4 out of the 6 sessions in the series. And at this point of time, I would like to thank everyone for attending today. And for those that would interested or would like to join a similar webinar, but in French, please log in to tomorrow at the same time for the French webinar. And next week, we are going to have an equally exciting session where we will be talking about the tools for that are being used. I would like to thank you very much and keep safe, and we will meet next week. Thank you and over.
Thank you.